So welcome again, everybody, to the Fall 2020 Faculty Forum. It's really a pleasure to see all of you and have our distinguished speaker here with us. I will give a brief introduction and then the presentation will start. As a reminder, please remember to mute your microphone when the presentation is on, unless you are asking a question. You also have the option of using the chat room for typing in your question. So today we have Dr. Jason Beckermann here with us as a speaker. Dr. Beckermann is from Detroit Lakes, Minnesota. He received his undergraduate degree from Concordia College and received his MD from the University of Minnesota. He completed his general surgery residency as well as his surgical critical care fellowship in the Hennepin County Medical Center in Minneapolis, Minnesota. He joined the Department of General Surgery at the Mayo Clinic Health System, Northwest Wisconsin, in 2007. And since 2015, he is the department chair of the Department of General Surgery at the Mayo Clinic Health System. So thank you very much, Dr. Beckermann, and the platform is all yours.
Thank you. Well, thank you for inviting me to talk here today. It's exciting, I think, to have this partnership between UWEC and Mayo, and I just see a lot of potential with this going forward. So I'm going to talk a bit about mesenteric ischemia and kind of how that's managed and how that has evolved over the years. And I think I was asked to give this talk today primarily because I had an opportunity in 2019 and then through the school year in 2020 to work with Ashley Walker, who participated in the undergraduate research education program here and worked with our department. And as a result of her working with us, we were fortunate that we were able to publish a case report on mesenteric venous thrombosis and acute appendicitis, and subsequently a case series on that in a separate journal. And that was really a great experience for me because we have a very busy clinical practice here and historically have not done as we do some research, but not as much. But I think this is a good opportunity really for us to collaborate and work together. So I think that's what primarily led to me talking with you all today. So I'm going to talk a little bit today about what mesenteric ischemia is, sort of describe the basic anatomy of this, how it presents, how patients show up in the emergency room or the clinic, how we end up treating those patients. Go through a few case presentations of patients that I took care of, a couple over a decade ago, and then a couple within the past year, just to sort of illustrate how this is different now and how the management has changed in these patients, hopefully for the better. And then we'll review some of the literature around endovascular versus open management, and then talk a little bit about the partnership between UWEC and Mayo. So what is mesenteric ischemia? If you don't do this on a regular basis, this isn't a term you come across every day, but it's really a narrowed or blocked arteries that restrict blood flow to the intestine. And this can happen in a few different ways that we'll get into, and it can happen just abruptly where there's a lack of blood flow, or this can be sort of a gradual process or a chronic problem that develops. And we'll talk about how those look different. So when you look at the blood supply to the intestine, there's really three major blood vessels that feed the intestine. We all have about 600 centimeters roughly of small intestine, 150 to 200 centimeters of large intestine. There's three major vessels that feed this. The largest vessel is the superior mesenteric artery. And then above that, there's a celiac artery that comes off just below the level of the diaphragm. And below those is what we call the inferior mesenteric artery. It's kind of behind all of this. You can't see in this picture, but that feeds a lot of the colon. And I think what's important to see in this is that this is the intestine has a very robust collateral network, that there's lots of branches that go between these different arteries. You can see between the celiac axis that there's branches that come down around the pancreas that go back to the superior mesenteric artery. All these branches and arcades in the small intestine, and then there's branches that go all the way from the the inferior mesenteric artery back to this middle colic artery. So even when one of these arteries is blocked, your body has lots of adaptations to try and accommodate for this. That being said, when there is a blockage that occurs, it's a very dangerous condition. There's a large amount of the blood flow that from the human body, of your cardiac output, how much your heart pumps with every beat, about 15 to 35% of that actually goes directly to the intestines. Your body has an amazing ability to adapt to low blood flow in the intestine. When your mean arterial pressure, normally that's the average blood pressure in your body is somewhere around 80 or 90. And when that's down to 45 even, your body can maintain perfusion to the intestine. So it's a really robust system with lots of redundancy built into it. When you look at the venous drainage, the veins carry the blood back to the heart. There's basically the portal vein is the main vein that ends up going into the liver, and then there's two major branches that feed that, the splenic vein and the inferior mesenteric vein. And when you see blockages of the venous drainage, it's a little bit different process. That what happens then is that there's the blockage that causes the intestine to slowly swell. It's sort of like when people get a DVT or a clot in their leg. They develop swelling of the leg. So this doesn't happen where people get such a sudden onset of pain, but it's a much more gradual process. Now, I'm going to show this next slide. I tried to keep out a lot of the stuff that's maybe a little bit gross to people, but there's a few things that I think are important to illustrate when we're dealing with this. So if anybody's kind of queasy, I'm just going to ask you to close your eyes for this slide, and I'll talk through the points, and I'll tell you when you can open it. So I'm going to switch slides here. So this is what we see when we look at acute mesenteric ischemia. So this is intestine, and this really dark intestine is intestine that has died, and this is no longer viable. It's not going to live. This intestine over here is stuff that we can still save. So it's really important when you see these patients that you try and salvage everything that you can in terms of intestine. This is a very rare condition, but when we see this, between 17 and 50% of people actually die from this problem. So it's a big deal when we see these patients. It's really critical that we identify this problem early and get on treatment as fast as we can to try and salvage as much intestine as we can. Okay, I'm moving on to the next slide. So anyone who wasn't watching that, you can open your eyes again now. So in terms of how does this happen, this is there's multiple ways that people can develop acute mesenteric ischemia. The most common way is the way I explain this to patients and to families. It's like a stroke to your intestine. So when you think of a stroke, there's a clot usually that breaks off from the heart or from the mesenteric or from the aorta and goes to the smaller vessels in the brain. The same thing can happen to your intestine. It's less common, but clots can break off from the heart or the aorta, and they go down and block the vessels that go to the intestine. The other ways that this happens is through a mesenteric arterial thrombus, where you develop narrowing of the arteries, and it just gradually decreases. The opening in the artery gradually decreases to the point where the lumen or the opening is so small that blood flow is limited and it clots. And that people often then have chronic symptoms before that happens. We talked a little bit about the venous thrombosis is a less common occlusion, and then non-occlusive mesenteric ischemia is a situation really where there's a problem with lack of overall systemic blood pressure. And there's some degree of blockage in association with that. I'm not going to talk about that quite as much, but we're really just trying to treat the underlying problem when that happens. So when we talk about embolisms or acute mesenteric embolism, the most common reason that happens is with atrial fibrillation. Most of us have heard of, or most people have heard of people being on warfarin or now some of these more common what we call NOAC medications, blood thinners for people who have atrial fibrillation or irregular heartbeats. When we see that, those patients are at high risk of stroke. They're also at high risk of having clots that break off and go to the intestine. This is an example of endocarditis, where people have an infection of the valves in the heart. These little plaques can break off and go to the intestine, as well as plaques in the aorta from atherosclerotic disease. When we talk about chronic mesenteric ischemia, that's more of a gradual process, as I mentioned earlier. This is what we've referred to as intestinal angina. Most people have heard of angina of the heart, where people have blockage of the arteries in the heart where they're narrowed, and then when they increase their activity levels and the heart requires more oxygen, patients will develop chest pain. The same thing happens with chronic mesenteric ischemia, where the arteries are narrowed, people eat, their intestines require more blood flow, and they develop pain in their abdomen when this happens. And ultimately, what that results in is inadequate nutrition and weight loss. And those patients are at risk of developing thrombosis at some point down the road if it's not treated. Now, that doesn't mean that everybody who gets pain after they eat, that this is the cause. In fact, this is quite a rare problem, but it is a very real issue. So when we see chronic mesenteric ischemia, what happens is that the arteries become narrowed. You can see on this is a CT scan from a patient where you can see the aorta coming down here, anterior to the spine, and people develop what we call these coral reef plaques, where there's large amounts of calcium and cholesterol that build up in the artery. This is that celiac artery that we talked about earlier, and the superior mesenteric artery. And when they develop all this cholesterol and calcium within the wall of the artery, that really limits the blood flow. In order for this to happen, it usually has to involve at least 2 blood vessels, 2 of the 3 major vessels, and the superior mesenteric artery almost always has to be involved. Most of the time, this is related to atherosclerotic disease. It can happen as a result of dissections or tears in the wall of the artery, and then rare inflammatory conditions. Interestingly, we do see a lot of this in older patients who get CT scans for other reasons, and they're able to compensate for this due to the robust vascular supply that the intestine has. So when we see patients where we're concerned about mesenteric ischemia, if it's an urgent situation, we typically will draw some basic labs, urine analysis, urine culture, blood cultures, and then the really important test. This is really almost an imaging diagnosis, and a CT angiogram is really the most effective test for diagnosing acute mesenteric ischemia. It's over 90% sensitive and specific, so it's very accurate in terms of identifying patients who have acute mesenteric ischemia. This is an example of a patient who has an embolus that has caused a blockage of the superior mesenteric artery. It may look to you like this is the problem here. This is the aorta. This is actually just the angle of the cut where this is open, but you can see flow down to here, and then this is the blockage in that artery where there was an embolus from the heart. In patients who have chronic mesenteric ischemia, we also use duplex ultrasound, which really gives us the opportunity to look at flow velocities or how fast the blood is moving through the arteries. And when you have a narrow tube and the blood has to go through there, it goes at a higher flow velocity, and that tells us that these patients have some degree of stenosis or narrowing of the arteries. So we correlate that with a CT scan to make that diagnosis. So I'm going to just talk about a couple of patients. Again, these first 2 are patients that I took care of years ago, over a decade ago actually, who came in with mesenteric ischemia. So the first one is actually a quite young patient for this problem. She was only 43 years old when she came in. She had a sudden onset of severe abdominal pain. She was vomiting and having bloody stools. She unfortunately was a smoker and diabetic, and when she came in, she was just miserable. It been very difficult to control her pain, even with a lot of pain medication. And interestingly, her abdomen was really, she was overweight, but otherwise quite soft. It was not distended. And what you see in a lot of these patients, they have what we call pain out of proportion to exam, where when you examine them, it's not that impressive, but they really have a lot of pain. And when this patient had her CT scan, you can see this is the superior mesenteric artery here, and you can see how the contrast is bright white. And when you get down here, you can see this is clot in that artery. The other thing that's, most people here probably aren't looking at a lot of CT scans, but this intestine is not normal. This is much bigger than it should be. And when you look at this right side of the colon, you can see air in the wall of the colon. And that to us indicates that intestine is either dead or dying. So we can tell this is a big problem. This patient, we started her on a heparin drip, which is a blood thinner, on antibiotics and IV fluids. She went emergently to the operating room. And when we do this kind of surgery, and we still do this sometimes today, but when we take these patients to the operating room, we We dissect out that superior mesenteric artery. We make an incision in that, open up the artery, and then we pass these balloon catheters called Fogarty catheters through there and take the clot out of the artery. And this is a very effective surgery. It works well, but it's very invasive, and it takes an incision basically from the bottom of the sternum down to the pubis, and it's a long recovery for patients. This patient ended up going back to the operating room multiple times, had significant amount of intestine removed, and she was in the hospital for over 3 weeks recovering from this. Ultimately, she did well, but it was a very long, difficult course for her. Interestingly, this lady gave me a plant that I had in my office for over 10 years. And I don't have a green thumb and wasn't able to keep this alive myself, but the nurses took great care of it. And unfortunately, it died about a year ago. And I thought, oh man, a little paranoia. Did something happen to the patient? Which I know there's no association, but interestingly, not long after that, I saw her in the hospital. She was in for a different reason and was otherwise doing well from a surgical standpoint. But interesting story. So this is another patient who came in with a thrombosis, a mesenteric ischemia related to thrombosis. And this lady is 84 years old. She had an interesting course that one of my partners had done a femoral embolectomy for her, where she had a clot from her heart that went down into her leg that he'd removed. And then she was started on blood thinners, and she had a GI bleed and was taken off of those, and then developed within a few days a sudden onset of severe abdominal pain. So when I met this lady, she was 84 years old, elderly, really frail, very overweight, and I was really concerned this lady was not going to get through this or be able to survive this sort of problem. And we could also tell from her CT scan she had intestine that had died, and this would be a big ordeal for her. And I really wasn't sure she would get through all this, but her family really wanted to be aggressive and do everything we could for her. So we took her to the operating room. And we did put her on a heparin drip, which is a blood thinner again, on antibiotics. And we ended up trying to do what I talked about before. We did an SMA embolectomy, but really couldn't get the artery opened up enough to get adequate flow there. So we ended up taking a vein out of her leg and doing a bypass to the superior mesenteric artery. And this isn't her picture, but this sort of illustrates what we can do, that we can take a conduit. You can either use a graft or a vein where you sew it to the aorta or the iliac artery and sew it to the superior mesenteric artery, and then restore blood flow there. This lady really had a difficult course where she ended up having multiple times back to the operating room, spent over a month in the hospital before she discharged to a nursing home. But ultimately she got through all this and lived and did well. The interesting thing about her was, as I mentioned, she was quite overweight, and through this whole process, she ended up losing a lot of weight, and it was a long recovery for her. But when I saw her back at 6 months after surgery, her family said with all the weight that she'd lost, this was the best she'd been in 10 years, that she was actually much more active and up and about and actually able to get up and go shopping. And I know she did well for several years after that. So, it was ultimately, I think, a success story, and this lady did well, but she really went through a lot to get there. This is just a picture of what these bypass grafts look like. We can use these grafts made out of Dacron to bypass blocked arteries. And then I just want to move on to how this has changed over the years and what this looks like now. We've went from an era when I was in my training and early in my career where most of these patients were managed with open surgery. And now the trend has went more towards doing more of these with endovascular options. And we'll talk more about what that looks like. But there's been several studies that have looked at how patients do and what their outcomes are like if we are able to if we're able to reestablish blood flow through open surgery versus endovascular surgery. And when you look at this, there's a large sample from the National Inpatient Sample where they looked at over 2,000 patients, or close to 2,000 patients who had acute mesenteric ischemia. And when you look at the chance of the patients dying when they had open surgery, it was about 39% versus about 25% when they were able to be revascularized endovascularly. Patients required less bowel resection. TPN is IV nutrition. There's fewer patients who needed IV nutrition after they had an endovascular resection, and they had shorter lengths of hospital stays. all of which we look at as good markers of a better outcome. Now there is, when you look at large samples like this, there is some selection bias where it's hard to say for sure that these patients weren't sicker. There's a reason that they had open surgery, but I think most of the data these days would indicate that if you can treat these patients with an endovascular approach, they do better. This is another similar study from just a single institution study from Cleveland Clinic, where they looked at patients who could present with acute mesenteric ischemia. Most of the patients were managed endovascularly. That's become their standard. And what they found, similar, less bowel resection. They found that patients had less kidney failure, less likely to have pulmonary failure after, and less likely to die when they were managed in this way. So there's still a lot of these patients that need surgery or a laparotomy, so it's not a solitary approach of only using endovascular options, but using that endovascular option to reestablish the blood flow is really, really critical, or really helpful if we can do that, I should say. The options for doing this, really there's a number of options. One is thrombolysis, where you can get into that artery, you're doing an angiogram and use medicines like TPA to break up the clot that's in there. And after that's been done, frequently we can use angioplasties, where we blow up balloons in the arteries to open these up, or place stents in the arteries to open up the arteries and improve the blood flow. And then the newest thing that's out there now is doing retrograde stenting, where we actually open up that mesenteric artery, and rather than do the angiogram through the leg or through the arm that we would do conventionally, you actually do it right through the superior mesenteric artery. And there's some definite mechanical advantages to doing this through retrograde stenting. And I think most of the data is saying that will be the wave of the future. So when we do these procedures now, what's really changed a lot in the technology is the ability to combine an operating room with a radiology suite. And this is what we call a hybrid operating room. So you can see this is a standard operating room table and anesthesia machine here. And this is a C-arm that we can bring in. It's got a robotic arm, so you can bring this in and do x-rays, do angiograms, and at the same time be operating on this patient. So everything can be done in one solitary venue, which means less anesthetics, less transferring the patients. It's really transformed what we can do from a surgical standpoint. This is a patient that we recently operated on, my partner, Dr. Najawan here, and this is actually an aneurysm surgery. But it illustrates what we've been able to do. And this is not only in mesenteric ischemia, but really even in trauma patients. This has really changed the standard of care, that many of these patients, they need an open surgery, but they also need an angiogram. And we're able to do both those things at the same setting, which is tremendous for patients. So this is really just a picture of what this looks like in terms of the incisions and what that looks like. I mentioned earlier, when we do these open revascularizations, we really have to make an incision along the whole length of the abdomen. When we do an angiogram, we use a small catheter that goes into the artery. And then this is what that incision looks like after you've taken that out. I mean, this is just a few centimeters. And when we talk about aneurysm surgery, I mean, it's amazing. These patients who used to have major operations, and now they go home the next day for almost 70% of the patients that we deal with now. So now I'm going to move on to a couple cases of patients that I've taken care of within the past year and how this has looked different and how these patients recover. So this patient was an 81-year-old who came in similar, where she had to the other patient we talked about earlier. She had a lot of medical problems, diabetes, heart disease, heart failure. She'd been sick for about 3 days with abdominal pain. When she came in, she had a high white blood count, a fever, indicating she had a bad infection. Her heart rate was high, and she had a very tender abdomen. I'm just going to run through her CT scan here. And I apologize, this takes just a little bit of a delay when we put this onto a PowerPoint. But this is actually the same scan we looked at just a still shot of earlier. But when we go back through this patient's CT scan, you can see how much plaque there is narrowing in that artery. And the other thing that's interesting is you go back here, you can see when we talked about air in the wall of the intestine, this is air in the wall of that large intestine. We can see that intestine is dying. So this patient, rather than starting with a large open surgery, we went to the hybrid operating room. My partner, Dr. McBride, who's an interventional radiologist, actually performed this portion of the procedure. He did an angiogram on the patient. So this is this catheter that's up inside the aorta, and this is the celiac artery. This is a little bit subtle. If you don't have a trained eye, this might not be real obvious, but this is the same patient. We looked at that CT scan. You can see this plaque in the artery, and this is really a narrowed opening, or lumen we call this. This is after he put the stent in the artery, and you can see this is reestablished flow through that celiac artery. I'm just going to show you an angiogram of what this looks like after he was done. Just going to step back so you can see what's happened here is that the stent is located here. This is the celiac artery, and we talked about all these branches that help feed the other arteries. This is that superior mesenteric artery that's so key to feeding that small intestine. So we're able to open up this one artery, the celiac artery, also open up, not directly, but to significantly improve the blood flow through the superior mesenteric artery, and really improve the blood flow to this patient's intestines. As soon as he was done with his portion of the operation, I did a laparotomy, opened up the abdomen, removed the intestine that was not viable or didn't have enough blood flow, but I could feel a pulse in the what we call the mesentery, where the blood vessels come through to the intestine, and you could tell this is dramatically improved. We did bring her back to the operating room a few days later to make sure that everything looked okay. But this patient was able to go home 10 days after surgery, and for an older patient with as many medical problems as she had, that's, to me, an outstanding outcome, and she did really well. Now, when we look at this in terms of the trends across the country, this was published in Journal of Vascular Surgery by Young Urban, who is one of the vascular surgeons at Mayo in Rochester. And when you look at the trends across the country in terms of how this has progressed over the years, the blue line is the number of patients with chronic mesenteric ischemia that are managed with endovascular options, and the orange line is the number that are managed with open options. And then when you look at the length of stay for patients who have an open procedure compared to those who have an endovascular option, it's a much shorter length of stay. And when you look at mortality rates, the number of patients who die after surgery, significantly lower in patients who are able to undergo an endovascular repair. So that's definitely becoming the trend. This is another patient who I've taken care of for a few different things in the past, and I actually referred her for this problem to one of my partners, Dr. Talarita, who does more endovascular work. He's a vascular surgeon. She was having postprandial abdominal pain, meaning intestinal angina, after she would eat. She'd had a weight loss of 14 pounds in about 2 months, and she was a very high-risk surgical candidate. She had bad aortic valve disease, and we knew if you put this patient under anesthetic and stress her body with a large surgery, she's not going to do well with that, or she has a high risk of complications. So we elected to treat her with an endovascular approach. She also had a stent placed. This is her angiogram. Now, he chose to come from the arm to do this, which is another way of doing this. This is her celiac artery. These are the renal arteries, the kidney arteries. He placed a stent in that artery. And similar to the last patient, you can see that just with opening up that celiac artery, you can see flow back to over here is the superior mesenteric artery. Just watch that one more time quickly. So by opening up one artery here, you're able to get blood flow back through both of those. This patient with this procedure was able to go home only 1 day after surgery, and when she came back at 2 weeks, her symptoms have completely resolved and she's eating without any pain. So that's really kind of covering the mesenteric ischemia from the arterial side of things. I'm just going to talk briefly about mesenteric venous thrombosis, since that's what Ashley and I were able to publish the papers on, and this is more a problem where the veins clot. There's a number of risk factors that can cause that. One of the major risk factors is patients who have an infection within their abdomen, people who have a hypercoagulable state, so they have certain mutations that cause them to have higher risk of blood clotting. This happens more frequently. And then the setting of trauma and previous surgery, there's also higher risk. So this is a patient who we talked about in our case report. He was 29 years old. He came in with a bad infection, bad abdominal pain, high fever, high white blood count. And interestingly, he had a CT scan that showed clot throughout the superior mesenteric vein. You can see up in this part of the vein, the arteries are normally white or gray, and then this is all clot through that artery. And then this patient had appendicitis, which you don't look at that, you probably don't know, but this patient had appendicitis. Normally with appendicitis, we would operate upon this patient, but in the setting of needing to be on blood thinners for this clot, that's a difficult decision. Do you go straight to the operating room, or do you try and delay that and treat the clot first? In this patient's case, what we did is we treated him with blood thinners, IV antibiotics, worked him up to make sure that he didn't have a clotting disorder. He actually went home on antibiotics and warfarin, which is another blood thinner, and then was able to come back in 10 weeks after the clot had resolved, and we were able to remove the appendix, and he did great, went home the same day, did not need to be back in the hospital for surgery. So just kind of summarizing, acute mesenteric ischemia, it's a rare problem. We don't see this often, but when we do see it, it is a high mortality condition. It's important that we identify these patients and treat them early. And the treatment for it has really changed over the years, that much more of this, we're trying to treat these patients initially with endovascular options. And we know that when we're able to do that these patients have a much faster recovery and a lower risk of dying in the short term. So it's definitely better for patients. Lastly, I just want to talk a little bit about this relationship between UWEC and Mayo. I think this has been a great thing from our standpoint. I really, really am optimistic that as we move forward, this is going to open up a lot of opportunities for research that's good for our patients. Hopefully, we're going to be able to innovate, create new technologies by working together. And it's a great opportunity for students. I think when Ashley was able to come and work with us, she was exposed to some quality improvement studies that we were doing in breast cancer care, bowel obstructions, and then in addition, spent some time in the dialysis, working in our dialysis unit, looking at some quality improvement we were doing there, and also the work that we talked about. So I think this is a fantastic experience for us as the physicians here, as well as the university, and really would look forward to the opportunity working with faculty at UWEC. And I think that's the next step of this, is how do we engage together to really improve care for patients in our region, as well as the educational process. That's what I have for today. Thank you very much for inviting me here, and I'd be happy to take any questions.
Thank you so much, Dr. Beckermann. Well, there is a question that just popped up in the chat room, and that says, what was Ashley's role in the research?
So yeah, when Ashley was involved with this research, so she helped with creating the tables that we had. She was involved with some of the writing and editing of the papers, and then it was a fairly small data set that we looked at, but with some of the data collection. So I really did try to get her actively involved in the writing process, because I felt like that was important. And then I did help with some of the getting papers on the topic that she could read to kind of get her started on this, and then she was able to pull some papers on her own in order to prepare for it.
Great. Do we have more questions? Actually, I have one, and that's one out of curiosity. So I was really, really impressed with the imaging assisted diagnoses. I wonder, is there any opportunity for using AI, artificial intelligence, to help with the diagnoses, as opposed to relying completely on a trained professional, trained eyes like you have?
Yeah, that's really, I think, the wave of the future. And I know one of my partners, Joe Wildenberg, has given a talk here in the past and did a lot of research in his PhD work on that. And it's interesting. In radiology and pathology, in those fields, there's a big effort to expand AI and do more automated reading for pathology and radiology, I definitely think that is going to have an impact on medicine and improve outcomes for patients in the future.
I mean, we can't replace the professional, and I can actually, with you pointing out, the area that we should be focusing on, I could actually see the difference. But without you there, I would have not be able to see. What's the difference? What are we supposed to be looking for?
Right. And I think where this is really valuable is even as clinicians with a trained eye, we tend to get tunnel vision. We sort of see a problem and your eye is drawn to that. And what a common error in medicine is there's an obvious problem and you miss something on the other side of the screen. And that's important. And I think that's where AI is really beneficial. And what I've seen is that it doesn't get tunnel vision. It looks at the whole screen. It's very logarithm driven. And I think that's where where AI will help in radiology. So it doesn't mean there's not a role for thinking and being able to evaluate in a clinician, but it avoids that type of miss.
Yep, definitely. Great. Do we have more questions for Dr. Beckermann? Do you see, Dr. Beckermann, any opportunity for extending this collaboration between Mayo and Eau Claire this summer, or are we all going on a pause because of COVID?
Yeah, it was really disappointing last summer. There were students who were lined up to work with us, and because of the whole COVID situation, that was put on hold last summer. I actually, before this talk, just did reach out to the coordinator to see where we're at with that. And it sounds like right now things are on hold. They're hoping that by next summer this will be up and running again. We'd love to have the opportunity to work with students, and certainly if any of the faculty are interested in projects that they'd like to collaborate on, we'd love to have that opportunity as well. So hopefully the undergraduate research education program will be up and running again this summer,
Yeah, right. Let's hope so. All right. Well, I see that time is 12:50, so I want to be mindful of your time and our attendees' time. So thank you very much, Dr. Beckermann, for your time, and thank you everybody for attending.